Hi, everyone. Welcome to OsteoBites, and thank you so much for joining us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Sowmya Ramesh from Johns Hopkins University to discuss her work investigating the sensory neural regulation of osteosarcoma. Thank you so much, Dr. Ramesh, for joining us today. We are thrilled to have you. A little bit more about our guest today before we get started. Dr. Ramesh is a postdoctoral researcher from the James Lab at Johns Hopkins University. And the lab's research focus lies at the intersection of skeletal pathophysiology and stem cell biology. The lab looks at the interaction of nerves in various musculoskeletal repair, including bone repair and regeneration, osteoprogenitor cell characterization, and neoplastic bone. Dr. Ramesh specifically works on understanding how peripheral nerve regulates osteosarcoma disease progression. Thank you so much for joining us today, Dr. Ramesh. We are really looking forward to your talk. I just have a few announcements before we get started. We have our next virtual tumor review board meeting for osteosarcoma, which we affectionately call TURBO. It's going to be on March 12th at 5 p.m. Eastern. Clinicians are welcome to present a case for discussion. Researchers are also welcome to attend to learn about real-world clinical challenges. And I'll put a link in the chat with more info about that. Also, factor registration is opening soon. In the meantime, please save the date, June 26th to 28th in Salt Lake City. Our scientific program will be announced shortly. Spoiler alert, Dr. Ramesh will also be there as well. So great opportunity to ask for more in-depth questions following this presentation in person. We are going to have a great lineup this year. Travel award applications are already open. There are a limited number of travel awards for both scientists as well as osteo warriors. Scientists can apply right now on Proposal Central, and those applications are due March 28th. And then for osteo warriors, we ask that they be nominated by a healthcare provider. And so I'll put a link in the chat as well, where you can find more information on eligibility and guidelines. And Dr. Ramesh, I'll hand it over to you now to get started. You can feel free to start sharing your slides. And everyone, please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Ramesh after her presentation.
Thank you so much, Christina, for the wonderful introduction and for the opportunity for our lab to present our work. So I'm just going to share my slides now. All right. So like Dr. Christina was mentioning, that our lab tries to understand how peripheral neurons regulate osteosarcoma disease progression. So I would just like to give a simple, a quick background on what exactly we are trying to study here. So this is a simple schematic of a long bone here, and we have the peripheral nerves that come from the dorsal root ganglion and the spinal cord. So what we see here is majority of the nerve fibers that actually innervate the bone is actually TrkA expressing or CGRP expressing nerve fibers. So what happens is NGF, that is the nerve growth factor, it binds to the receptor tropomyosin kinase on the nerve terminals over here, and that initiates the pain signals that we actually feel. So over the past decade, our lab has actually worked on teasing apart how the nerve fibers actually regulate bone repair as well as in other disease contexts. So what we see here towards the left is an uninjured bone, and we can see the nerve fibers that are pretty much organized, as we can see in the high mag over here, the Thigh-1 nerve fibers. But in response to a stress fracture, what happens is the nerve fiber starts to be pathologically sprouting over here. So this led us to wonder if in the context of an extremity trauma, as we see here towards the right, which is heterotrophic ossification, where we can see that these nerve fibers indeed proliferate more over the period of the disease progression. So both in the context of bone repair as well as in the context of disease progression, these nerve fibers tend to aberrantly proliferate. So made us wonder what happens in the context of a malignant bone tumor, as in this case that we study osteosarcoma. So our premise or the hypothesis is that the tumor cells or the osteosarcoma cells, they release NGF, and that starts to recruit more nerve fibers around the vicinity, and they start to proliferate more. And this in turn regulates the tumor progression, as we are going to see in the animal model that we have used. So to test this hypothesis, whether peripheral nerves regulate osteosarcoma, we utilized somewhat close to a human osteosarcoma model. That is, we orthotopically inject the human osteosarcoma cell line into the bone, as we see here towards the left on the H&E image. So this is bone, and then we have the kind of an irritated periosteum that's lining. And here we have the sarcoma that's grown after like 7 days after the tumor cell injection. So we confirm that these cells are human, and by immunostaining for a human nuclear antigen, as we can see here, and the nerve fibers that are over here are the Taiwan YFP, that is, these are the transgenic mice that do express Taiwan. So in order to confirm that these tumor implants indeed express NGF, that is the nerve growth factor, we performed immunostaining for NGF, as we can see here in these tumor implants. And we also looked at the NTrkA1, that is the TrkA expressing nerve fibers, as we see here in the yellow. So this in parallel, we also looked at some of the human osteosarcoma samples that we did have, and we confirmed, or these observations did mirror, that the human cells do express NGF, and we do have aberrant nerve proliferation all around the sarcoma implants. So in order to validate the findings, not just in one cell line, but also in other, we looked at the expression of NGF and other neurotrophic factors in multiple cell lines, as I have listed here, that majority of the cell lines do express NGF as a driver in most of the human cell lines that has been used in most of the studies. So we also looked at the NGF expression in neoplastic bone that were from a publicly available data set, that we do have increased expression of NGF compared to the non-neoplastic bone. So having confirmed that the NGF and TrkA is indeed present, we wanted to typify these nerve fibers based on sympathetic and sensory. So what we see here in the panel A is a marker, like a pan-neuronal marker, that's beta-tubulin 3 over here, that's in an uninjured bone, and CGRP, which is a sensory nerve marker in an uninjured bone. So in response to a tumor cell injection, these nerve fibers start to sprout more around the sarcoma implants, as I'm showing here in the panel B, panel C to E. So these typify that indeed that the pan-neuronal marker, such as TUP3 and sensory nerve marker CGRP, they do sprout aberrantly in response to the tumor cell. So having done this, we wanted to more carefully analyze the interaction between the peripheral nerves and the tumor cell. So we sort of did some spatial analysis, where we looked at how far are the tumor cells having the nerve in response to the nerve fiber. So when we did some measurements, we found that most of the nerve fibers were present along the sarcoma periphery, as we can see from the graph over here, that suggests that they do not really infiltrate, but rather they are just present outside the sarcoma periphery, as shown clearly here in the rendering image over here to the left. So having found that NGF and TrkA are an important mediator of osteosarcoma, we wondered what if we impair the TrkA signaling or the TrkA neuronal signaling, and whether that would mean anything in the context of osteosarcoma regulation. So we use these genetically modified animals. So these were the TrkA wild type and the TrkA mutant animals, as we call. So they have a point mutation in the TrkA receptor that makes it susceptible for a small molecule, that is 1-NMPP1, to inhibit the neuronal signaling. So what we did was to cross these wild type and the mutant mice with SCID, so that we can allow for human sarcoma cell implantation, and then you can monitor the tumor growth. So using this model, we performed the tumor growth studies where we found that when we disrupt the TrkA signaling, we found over a period of time that there is a reduction in the tumor growth by about 50%. So when we disrupt the TrkA neuronal signaling, we found these tumors to grow low as early as day 10, and that sustained up to 4 weeks after implantation. Not just that, we also looked at the survival curve of the wild type and the mutant animals, and we found that the mutant animals did survive for a longer period of time compared to the wild type. So this suggests that there is disruption of TrkA signaling can shrink the osteosarcoma growth and also prolong the overall survival. So next, we try to look at more downstream analysis as to what happens to the innervation. And as we can see here, we saw a reduction or like an 80% reduction in the nerve fiber density as quantified here. And that also led to a reduction in the vascularity as shown here by endomucin stain. And we also have the Ki67 that was reduced by about 80%, suggests that the overall tumor growth is reduced, and the consequences is reduced innervation, reduced vascularity, and reduced proliferation of these tumor cells. So this is where I try to lose my audience, but then I would try to hopefully do a good job in explaining. So we were wondering what makes the tumor to grow in a smaller size. So I guess what we did was we returned to the sarcoma implants, and we performed single cell sequencing of both the TrkA wild type and the TrkA mutant animals. That is probably 2 weeks after injection. And then we try to study their downstream mechanism as to what happens in the mutant animals compared to the wild type. So what we see here in the top panel is the UMAP projection of the wild type and the mutant animals, as we can see here. And we do have tumor cells and the tumor microenvironment cells that are over here, that are composite of neutrophils, lymphatic endothelial cells, and fibroblasts. And we have the human tumor cells over here. So we made sure that we tag them along correct based on the gene markers as listed over here to demarcate the tumor cells and the other cell types in the composite. And we try to study just the tumor cells by itself. And we looked at what are the gene ontology terms that does come up after inhibition. So what we found was the interesting terms that came up was the axon neuron extension that were more enriched in the wild type compared to the mutant. And we also found a lot of interesting terms related to bone chondrocyte differentiation and reduced angiogenesis, suggesting that we were able to mirror what we saw in the previous, in the immunohistochemically, that there is indeed a reduction in angiogenesis as well as in some sort of a bone chondrocyte differentiation. When we looked at the tumor environment by itself, that is a composite of all these cell types, and we try to analyze what exactly, what are the cues that these cell types are actually giving it for a reduced tumor to grow. And we found that endothelial cells, as well as, again, some of the guidance by the nervous system to be upregulated in the wild type compared to the mutant. So having, so this sort of gene ontology terms led us to intervene more on the peripheral nervous system as suggested here in the GO. So what we did here was to try to computationally understand the interaction between the nerves and the tumor environment cell types. So this is actually a busy slide, but I would try to explain this in a better manner. So we have a mixture of other cell types that we did see in the previous slides, right? And we have the tumor cells and the neurons that expresses TrkA and the neurons that are non-TrkA expressing. So this is a virtual interpretation of how these tumor cells could interact with the peripheral nerves with and without TrkA, and also with other cell types to bring about this effect that we are actually seeing. So what we did was when we extracted the information that is the interactions between the tumor cells and the TrkA neurons, because that is our topic of interest that we are trying to look at. When we try to extract those information, we found like an array of signaling pathways that are deranged in the mutant mice compared to the wild type. So, but something that was of interest was the neurotrophin signaling and NGF and TrkA signaling as the top list. So when we looked at it, we were wondering whether which of these signaling pathways are exclusively mediated by TrkA expressing neurons, because like I said, the animal model that we are using are for TrkA. So we were wondering which of these pathways are exclusively mediated by TrkA positive neurons and which of them are not. That's how we sort of oriented our study, like the signaling pathway studies that we are listed here. So we found that the TrkA signaling was the one that was most enriched in the TrkA expressing neurons compared to the non-expressing neurons. So we wondered if TrkA, which is like the CGRP, like the neuropeptide, when are they actually different between the wild type and the mutant implants? And we did find that these the CGRP expression on the tumor was reduced in the mutant mice compared to the wild type, suggesting that there is a link between the peripheral neurons secreting CGRP and the tumor growth. So I guess so far we have just looked at the whole idea that the peripheral nerves actually do regulate osteosarcoma growth, and we identified a signaling pathway CGRP. But what does it mean in the context of therapeutic context? So we wanted to look at more, we wanted to use a more like a drug which could be used as a therapy, but also, already tested, and like we wanted to repurpose a drug. So we came across this FDA-approved lipid nanoparticles. That's bupivacaine. As we all know, it's an analgesic, and they were recently this formulation was approved by Exparel for local administration for post-surgery. So what we did find was there were a couple of other studies that did mention that not just the analgesic, but at a particular dose, it does inhibit the neurite growth. So we were curious to see if it's true in our model. So we tried to test or we tried to repurpose the bupivacaine liposome to inhibit the neurite growth in response to the tumor cell inoculation. So what we did find was, the study was done in non-skin mice, and we have the control, that's PBS injection, and bupivacaine injection in another cohort of animals. And this is the tumor volume over a period of 4 weeks. That suggests that as early as day 10, there is these tumors grow slowly compared to or they have reduced tumor growth compared to the PBS or the vehicle injection. And these are the concomitant pictures that suggest that about 60% reduction in the tumor growth reduction in the animals that received L-bup. So we also confirmed that not just the negative regulation of tumor growth, but also we confirmed that the bupivacaine did have they had low paw withdrawal frequency. That is, they relieved pain in the animals that were treated with bupivacaine compared to the vehicle injected group. So we were trying to characterize the tumor implants, again, based whether there is reduced innervation or not in these L-bup treated animals. And we did find that there was a reduction in the pan-neuronal marker beta-3 tubulin in the L-bup treated animals compared to the PBS. And this was also true in the case of the Ki67, which is a tumor cell proliferation, and as well as in the context of the vascularity that did reduce in the L-bup treated implants. So I guess what I'm trying to quickly summarize what we did learn so far from our studies is that we found that the peripheral nerves, they start to sprout aberrantly in response to osteosarcoma implantation. And that was consistent across human osteosarcoma as well. And when we sort of disrupt the TrkA nerves, it reduces the axonal ingrowth, but also it reduces the tumor growth and the progression, as we saw from the tumor growth and the survival curve that we saw in the previous slides. And the mechanism that we believe that this is based on the sequencing, that the CGRP signaling is altered in this context. And also we found a more like an adjuvant therapy by using LBU as a way to reduce the tumor growth or shrink the tumor prior to the standard of care of removal of prior to surgical. So I do have a lot of other slides that we could discuss based on the questions that we have, because we have some interesting studies done on human DRGs, like reanalysis of human DRGs that were then in the context of pain. But I guess for the interest of just to keep it short, I think this is what we have for now. And this is most of what I presented today is actually available as a preprint on bioRxiv. And we thank this is our team, and I think this is our team from James Lab at Hopkins, and these are our different funding resources, and we have our collaborators. And yes, I think I will be happy to meet some of you or most of you at the Factor 2025. Thank you so much. Christina, over to you.
Thanks so much, Dr. Ramesh. Everyone, please feel free if you have any questions to put them in the Q&A, and maybe I will kick off with a couple. So I thought that was so, interesting because of the, I think a lot of times we hear about angiogenesis in osteosarcoma, and there's definitely been, kind of looking at use of VEGF inhibitors in osteosarcoma. And this is kind of looking at something similar, but with nerves, right? Like the innervation. And can you maybe talk a little bit, I think in your preprint, you might kind of get into this a little bit, but the kind of relationship between angiogenesis and innervation, which one is the driver and how do those kind of interact?
Yeah, I think that's a fantastic question. I think the idea here is, so we have studied endothelial cells in the context as a secondary mechanism in the context of denervation, but the primary driver is when you have less nerves, you have less vessel as well, like the blood vessel. So both go hand in hand. So I think we, to answer your question, I think we just have to do a study that does touch upon the vascularity exclusively, because like you said, even just impairing the vascularity like VEGF-R can also reduce the tumor growth. But here we are trying to see a direct interaction between peripheral nerves and the tumor cells. So, and then as a consequence, we have reduced vascularity as well. So it's a tricky question to answer, but like I said, I think we have more future plans to study the question just like you proposed. Like it makes us wonder too, whether if it's the less vascularity that's actually leading to less tumor growth, or is it the less nerve frequency that's actually causing this? But I guess we are more pro to the direct effect that I mentioned, that less frequency of nerves that does impair the tumor growth.
Yeah, it would be interesting to look at the impact of VEGF inhibitors on the TrkA signaling, or maybe, and then a combination of some of the other agents that you noted.
Yes. I think there are studies that does, so usually for TrkA inhibitors, they use two FDA-approved drugs that are already being used, entrectinib and larotrectinib. So they are most commonly used as TrkA inhibitors. But I guess that's expression on the tumor cells as such, because so the confusing part here is the tumor cells do express TrkA, But what we are saying is the peripheral nerves that expresses TrkA, right? So it's a different, like we are trying to target those peripheral nerves not to invade the sarcoma, rather than the other way around. So, but yeah, I think it always like I said, we still have a lot to answer here. Yeah.
Yeah. And one thing I really appreciated about, both your presentation and your preprint is really trying to kind of focus on takeaways for clinical translation and some possible implications. So you did discuss some other targets. I guess, so if you can maybe kind of expand on that a little bit more. I think you had kind of discussed NGF, like being able to target NGF with monoclonal antibodies, and then certainly larotrectinib and entrectinib for TrkA. And then I think you had also mentioned there's some FDA-approved antibodies for CGRP.
Right, that's correct. So yeah, that's something brewing on its way. So we found it interesting because we have CGRP that's FDA approved for migraine currently in use. So, but I think now that we found not just our work, but then we have other tumors, for example, gastric cancer as well as pancreatic cancer, that do have the CGRP signaling that as a main driver for tumor growth. So I guess right now the hot topic is to use such monoclonal antibodies that target CGRP to see if it is true in the case of bone sarcoma, because we do not know yet. So what we know from the literature is it does have an effect on pancreatic and other tumors, because most of these tumors, they have NGF as their driving factor, right? So I think that's something that we are planning to do in the near future, to use some CGRP antagonists to see if what may be the effect in that case. Yeah.
And so the other interesting approach was using the bupivacaine. I don't know if I'm pronouncing that correctly.
Right.
It also is currently around and has been FDA approved for use in children, I think older than 6, right, for some other.
Right.
And so I'm curious, like I know today often drugs like gabapentin are used to manage nerve pain,
yes.
in osteo patients. And what about like the effect of something like a gabapentin on TrkA expression or signaling?
I don't think I'm aware of such a study, at least done in osteosarcoma as such. But yes, I think there are studies that use gabapentin because the nerves are really irritated, and then they try to calm that down using gabapentin. I've seen studies that use, but I'm not quite sure as to what happens in this context of a tumor that has. I think it also depends on like the time of intervention, because all the studies that we have done is mostly on early time points where we see maximum nerve to be sprouted, because over a period of time we don't see the nerves, but we see more of a tumor. That's because the tumor starts to invade the whole the whole bone. So we don't really know. I think whatever the therapy that we are proposing is the timing would be a key factor here to address but I think, we do have a lot of other options to see if if it could inhibit the tumor growth or not. But yeah, I think I'm not sure about the gabapentin, how that may help.
So actually, that's a good point about the whole timing thing, because I am trying to understand, like in a clinical setting. So, because usually what happens is you're diagnosed, there might be a biopsy up front, but then you start on the neoadjuvant chemotherapy, and then the surgery kind of happens after a couple cycles of that. And so, where I guess how would this potentially impact that primary tumor and determining like where you would potentially have the opportunity to use the bupivacaine? If it's is that resection, you're already kind of removing the tumors, or are you just kind of adding that to kind of prevent any local recurrence? Or
right, I think this is a good point. And the idea here is we try to the whole idea is to, as an adjuvant therapy, to shrink the tumor size before resection is the whole idea, because I don't think it's not going to completely abolish the tumor. We do still see tumor growth, but then it sort of arrests some of the tumor growth. So the ideal world would be to shrink the tumor size with the drug, and then post, anyway, I think the surgical management is still necessary in this case. But I think that's where targeting by different other modalities, such as CGRP, or which modality would give the maximum reduction in tumor growth, would be something that what we are looking at in an ideal world prior to chemotherapy or prior to resection, I would imagine.
Yeah, and is there what is the impact? I guess I'm trying to also understand on local control versus preventing metastasis. Because certainly the goal is to kind of prevent like a recurrence locally. But how does kind of, minimizing and trying to decrease the innervation kind of impact potential pulmonary mets?
So I think I didn't give that particular data over here, but we did see pulmonary lung mets lower. That's available in the preprint, that we do see in the TrkA mutant mice, like without the TrkA, upon TrkA inhibition, we do see less mets compared to the ones that were in the wild type group. So, but again, as I see, these are again, the limitation is that these are animal models, and we will not have as much as possible effect here. So I guess we did see, at least in the TrkA animals, we did see less tumor, like the mets compared to the wild type. But yeah, I think we need to see exclusively a study for what we are addressing if you're going to pitch in more in detail, I would imagine.
Yeah. Well, this was really interesting. Again, just kind of gave another angle to kind of really understanding, the bone biology and kind of figuring out like another way. And again, it would be an interesting combination therapy, because we, kind of know that for osteosarcoma, we kind of need to tackle it on many fronts. So this kind of gives us another angle to look at. So very interesting. Thank you so much. Really appreciate your joining us today, and for all you do to make it better for osteosarcoma patients. We are going to be joined next week by Dr. Michael Lizardo from BC Cancer Center. He is going to be discussing how pharmacologic inhibition of EIF4A blocks NRF2 synthesis to prevent osteosarcoma metastasis. And I also just wanted to highlight, we have our February Osteo podcast that's already out right now. You can find it on our YouTube channel and at your favorite podcast place. And our co-hosts Mia and Sammy spill the tea on all things osteosarcoma and AY8 cancer. And this month they discuss how pets become their greatest sources of comfort, laughter, and unwavering support during treatment and recovery. The episode is called Pause and Reflect: How Pets Help Us Heal. So a kind of a fun listen when you have a moment. And you can find our OsteoBites lineup for the next few months on our website. If you ever have any ideas at topics that you'd like to hear about, please email us at events@mibagents.org. Thank you again, Dr. Ramesh, for spending an hour with us today. And thanks to everyone else for taking time out of your busy day to join us here on OsteoBites. We hope to see you back here next week on March 6th when we chat with Dr. Michael Lizardo.
Thank you so much.
Thanks so much, Dr. Ramesh.